Hi, my name is Trasient, and I am going to talk about Polyhydramnios, Trasient, Antenatal Bartter syndromes, and MAGED2 mutations. Definition: Antenatal Bartter syndrome is a potentially life-threatening disease characterized by fetal polyhydramnios, prematurity, and postnatal polyuria with persistent renal salt wasting. The known genetic cause of antenatal Bartter syndrome directly affect the molecules that mediate salt reabsorption in the Higgs ascending limb of the loop of Henle.
Bartter syndrome. It is a congenital disorder. It is a autosomal recessive disorder. And this condition mimics like prolonged ingestion of loop diuretic like furosemide. Okay. So before I discuss the topic of Bartter syndrome, let me discuss the basic concept about what is the mechanism of furosemide and how it resembles Bartter syndrome. So here is the nephron, and this is the ascending loop of Henle. And we know very well in our physiology, in the basic concept, that ascending loop of Henle is permeable only to sodium chloride. In other words, in ascending loop of Henle, only sodium chloride is reabsorbed. This part is not permeable to water, so water is not reabsorbed at this place. Loop diuretic like furosemide act at this site. Now, when we give loop diuretic, so obviously this sodium and chloride are not reabsorbed at this place, ascending loop of Henle. So large amount of sodium chloride goes out and it carries water with it. That's why we get polyuria when we are using loop diuretic. So as the volume contracts, in compensation, body secrete large amount of aldosterone. A is for aldosterone. Okay. Normally, let's talk about normally. Suppose two sodium are reabsorbed, and as two positive particles have come normally in the body, as per law of electrostat, body has to secrete two positive ions. So normally one H ion goes out and one potassium goes out. It's just to explain to you. Now when we are using loop diuretic, and I told you this excess of aldosterone secretion occur. That means loop diuretic create a state of hyperaldosteronism, secondary hyperaldosteronism. Now suppose now 4 sodium are reabsorbed. Okay, normally 2, now 4. Now 4 positive particles have come. It means as per law of electrostat, body has to secrete 4 positive particles. So now body will secrete 2 more positive, 1 H ion and 1 potassium. So excess of sodium is coming in, excess.
Hello everyone, I am Dr. Naveen Porwal, your mentor educator at Academy Plus. So today we are going to discuss a very important topic, Bartter syndrome. And to understand Bartter syndrome, we should know the basic physiology of thick ascending loop of Henle. So if we make a diagram of thick ascending loop of Henle, we can see that there are various pump and channels which we should know for better understanding of Bartter syndrome. Okay, for that we should know at least that the primary pump is sodium potassium pump. Okay, the primary pump is sodium potassium pump, and this is the channel called as NKCC, sodium potassium 2 chloride channel. Okay, then we have various ROMK. They are present on the basolateral as well as luminal, but basically they are causing secretion of potassium. After reabsorption, they are causing secretion, and they are called as ROMK channel. And then there are chloride channel also. For that, two things are necessary. One is called as Bartter, and other is called as CLCKB and CL, it is CLCKA. There are two channels. Okay, so if there is mutation of these pumps or channels, there can be Bartter syndrome, and they are of various type. Like for example, if there is mutation of NKCC channel, it can cause type 1 Bartter syndrome. It is called as type 1 Bartter syndrome. If there is mutation of ROMK channels, it is called as type 2 Bartter syndrome. If there is mutation of CLCKB, okay, it is called as type 3 Bartter syndrome, and it is also called as classical Bartter syndrome. It is also called as classical Bartter syndrome, and if there is mutation of Bartter, then it causes type 4 Bartter syndrome, and this is the only Bartter syndrome which is accompanied by sensorineural deafness. It is accompanied by sensorineural deafness because these chloride channels are also in the internal ear cochlea. So when Bartter is mutated, then there will be problem in the hearing also. So there will be accompanied hearing loss. Then you might ask me that why not, if there is CLCKB mutation, why classical Bartter syndrome or type 3 Bartter syndrome is not accompanied by sensorineural deafness? Answer is that when there is mutation of CCLKB, okay, it is compensated by CCLKA. That is why it does not have any types of sensorineural deafness. Okay, so there are four main types of Bartter syndrome. Now, the drug which is acting on this pump or blocking this pump is, they are loop diuretics. So loop diuretics like furosemide are behaving like Bartter syndrome. They are behaving like Bartter syndrome. So what can be the feature? If you want to discuss, let me see one by one. The first thing which you can see here, that there is salt wasting. There can be salt wasting because of blockage of NKCC channel. There will be salt wasting, so that can cause polyuria also. That can cause dehydration also. Okay, so polyuria will be there, and there can be also dehydration.
Applications in medicine. Polyhydramnios occur exclusively in pregnancies with male offspring. We filter the result obtained by whole exome sequencing analysis of DNA from patient and his mother for rare shared X chromosomal variants, minor allele frequency. Both the mother and the son carried announces mutation. The result is a premature stop codon in MAGED2, which encodes melanoma associated antigen D2, MAGED D2.
Hi, I'm Dr. Jennifer Gaviani. Today we're going to talk about a topic really important to patients who purge, and that is, why do you get so much edema or fluid retention when you stop or decrease purging? Here's how it works. When your body is chronically dehydrated, your brain thinks, I have to upregulate any hormone I can to make sure that I hold on to water and salt if I should come across an oasis in this desert. That's what it does. Your adrenal glands overproduce aldosterone, causing a secondary hyperaldosteronism called pseudo-Bartter syndrome, and that makes you retain tons of fluid when you stop purging. It also makes you dump potassium in your urine. There is a way to treat this properly. For more, go to www.gavianiclinic.com.
Pros and cons. The pros. Prognoses that tend to be more positive occur in patients who do not develop severe disease. Cons. Low blood pressure, hypokalemic alkalosis, hypercalciuria, and nephrocalcinosis. Elevated plasma renin and aldosterone levels, vascular resistance to angiotensin II.
Bartter syndrome is a rare inherited defect in the thick ascending limb of the loop of Heen. It is characterized by low potassium levels, increased blood pH, and normal to low blood pressure. There are two types of Bartter syndrome, neonatal and classic. A closely associated disorder, Guyt-Hellman syndrome, is milder than both subtypes of Bartter syndrome. Features: in 90% of cases, neonatal Bartter syndrome is seen between 24 and 30 weeks of gestation with excess amniotic fluid. After birth, the infant is seen to urinate and drink excessively. Life-threatening dehydration may result if the infant does not receive adequate fluids. About 85% of infants dispose of excess amounts of calcium in the urine and kidneys, which may lead to kidney stones. In rare occasions, the infant may progress to renal failure. Patients with classic Bartter syndrome may have symptoms in the first 2 years of life, but they are usually diagnosed at school age or later. Like infants with the neonatal subtype, patients with classic Bartter syndrome also have polyuria, polydipsia, and a tendency to dehydration, but normal or just slightly increased urinary calcium excretion without the tendency to develop kidney stones. These patients also have vomiting and growth retardation. Kidney function is also normal if the disease is treated, but occasionally patients proceed to end-stage renal failure. Bartter syndrome consists of hypokalemia, alkalosis, normal to low blood pressures, and elevated plasma renin and aldosterone. Numerous causes of this syndrome probably exist. Diagnostic pointers include high urinary potassium and chloride despite low serum values, increased plasma renin, hyperplasia of the juxtaglomerular apparatus on renal biopsy, and careful exclusion of diuretic abuse. Excess production of renal prostaglandins is often found. Magnesium wasting may also occur.
Issue apply in Ecuador. Patients who have these syndromes, they may have intrauterine growth retardation and polyhydramnios. They may be born prematurely and may have poor postnatal growth and development, and some children have intellectual disabilities. And finally, in the conclusion, we found that MAGED2 mutation cause X-linked polyhydramnios with prematurity and a severe bad Trasient form of antenatal Bartter syndrome. MAGED2 is essential for fetal renal cell reabsorption, amniotic fluid homeostasis, and the maintenance of pregnancy. Thank you.